Looking at antiemetics generally, for the older patient, tolerating chemotherapy and tolerating treatment is a big issue. Where do we stand with antiemetics in older patients with cancer?
Before I answer directly your question about the older patient, I think we should realize that in the past year there have been major advances in antiemetics. There are two drugs that have been recognized by FDA and EMA in the setting of antiemetics. They represent what we call the NK1 receptor antagonists. One of them is called rolapitant. This drug is given separately from the other drugs, is very efficacious as aprepitant was and continues to be. Has a potential advantage of having no drug-drug interaction in the sense that it does not affect what we call the CYP3A4 pathway of metabolism. This is important for elderly patients because they have often 2, 3, 4, 5, even more drugs to take. And anything that could potentially influence the metabolism of any other drugs is something that we might want to avoid. Now we know that this is very theoretical because there have not been any reports of major issues with the aprepitant, so this advantage could be considered somewhat theoretical. The other drug that has been developed is netupitant, which is actually developed along with palonosetron in a capsule that I call abbreviated NEPA, netupitant plus palonosetron. In one single capsule, you have an NK1 receptor antagonist and a 5-HT3 receptor antagonist. So you have the combination of the two key drugs, which along with corticosteroids improve the response rate of patients that have chemotherapy to very high levels, making that vomiting today is extremely rare, nausea is still not fully controlled.
What is the issue about QTC interval and how big an issue is that?
Thank you for asking the question about QTC interval. This is indeed very important for our elderly patients. They often have cardiac issues. There's a warning that has been put forward by FDA and EMA about the citron, the 5 receptor antagonist, except for palonosetron. The only one that does not have this warning. For the others, there is a potential prolongation of QTC which can lead to cardiac arrhythmia. So if we can avoid that, much better for the patients.
All drugs have toxicities though, so how big an issue has that warning been practically?
In practice, it's a rare event, fortunately, very rare event. So authorities have had to collect quite a few observations before they came out with this warning, but now the warning is clearly there. So again, there's also some data to show, and all guidelines concur, that if you're using a 5-HT receptor antagonist just by itself, because there's no indication for an NK1 receptor antagonist together, then palonosetron is preferred drug because it is somewhat more efficacious than the standard citrons.
But you have done a very interesting study with NEPA. This is a combination approach. Tell me about that, please.
Well, there have been several studies that have led to registration of this combination netupitant and palonosetron, and I'm presenting here at the Geriatric Oncology Conference a paper showing that it's not on the first cycle, the second, third, fourth, fifth cycle, patients have a benefit, and this is true in the elderly patients and the younger patients without any excessive toxicity in the older patients.
So the combination is turning out to be recommendable in your view?
Certainly the combination is now accepted in guidelines for the highly metagenic and carboplatin and AC-like chemotherapies.
It seems then, for the cancer doctor in everyday practice, there is quite a range of possibilities for Antiemesis. How would you guide the doctor to sum up then in how she or he should approach Antiemetics now for the cancer patient, especially the older cancer patient?
I believe that the way to go is to follow the guidelines. They all come to the same recommendations, and to use a triple combination in patients at high risk of nausea and vomiting, i.e. cisplatin, carboplatin, and AC-like chemotherapy in female patients.
And the place of the new combination therapy, where might that be in those guidelines?
Well, the combination of netupitant and palonosetron being a single capsule, that makes it easier for the patient to have one more tablet to take. Rolapitant, as I said, is given separately, but has the potential advantage of having no drug-drug interaction with CRP3A4 pathway. But as I said, it might be only theoretical.
So in a nutshell, how much have things improved?
Well, things have improved a lot. But we still have to work on nausea. Nausea is still something that patients complain about, but we don't really know what nausea really represents.
And what about dosing issues to moderate that too? I mean, obviously you want to give full dose, but can you back off the dose?
No, the Antiemetics should be given as prescribed in the label. But there is one question, which is the dosing issue, in the sense that we used to give higher doses of some of these 5G receptor antagonists in the past, and these have been related a little bit more to QTC intervals. So the authorities have now stated for some of these drugs we have to use a reduced dose.
And in older patients, chemotherapy dose is an issue because doses might well be different from a younger patient. Is that something that affects all of this?
Well, this is a very, very important field you are asking me to discuss, is the relationship between the dose and efficacy. For cytotoxics, when the patient has a tumor which is really sensitive to cytotoxic agents, we have, I believe, enough evidence to say that it's important to maintain dose intensity. And I had the opportunity to present at this meeting data on the use of G-CSF according to the guidelines of EORTC, which are very similar to the ASCO guidelines, actually were developed in parallel. And there is sufficient evidence to say that the elderly patients at a higher risk of febrile neutropenia, and in order to maintain dose intensity where there is curative treatment with chemotherapy, we should absolutely use G-CSF. We should not dose reduce.
So the brief take-home message, it's a bit complicated now. We're talking about dose of chemotherapy, but also antiemetics. What should doctors be taking home from this in just a few words?
In just a few words, unless there's a compelling evidence that the patient might not tolerate the treatment, we should be aiming to give the patient the treatment as for a younger patient with appropriate support, i.e. G-CSF, if needed, erythropoietin, appropriate antiemetics in order to give the full dose. If it's palliative treatment, then we have to think of the quality of life first and not about the quantity of life. And then the discussion becomes very much patient-centered on what is the patient's ultimate goal.